Welcome to the Transforming Trauma podcast. Transforming Trauma is presented by the Complex Trauma Training Center. I'm your host, Emily Ruth, and I'm so glad you've joined us today. Are you a mental health professional looking to deepen your clinical expertise in healing complex trauma? We're thrilled to announce our 2025 NARM Therapist trainings designed to provide you with transformative training in the neuroaffective relational model. In 2025, we're offering 3 Level 2 NARM Therapist trainings, 2 live online cohorts, and 1 in-person training in Scottsdale, Arizona. Both the in-person Scottsdale training and the spring online cohort begin in January of 2025, and the summer online cohort begins in May of 2025. These NARM Therapist trainings consist of 4 weekend modules spread out over the year. Through this advanced clinical training, you'll learn how to confidently and compassionately heal the impact of adverse childhood experiences and C-PTSD. You'll gain specialized training in a relationally focused, neurobiologically informed clinical approach that supports the resolution of attachment, developmental, relational, cultural, and intergenerational trauma. And you'll be joining a dynamic community that offers multiple learning opportunities to deepen your professional and personal growth. Enrollment is open to licensed psychotherapists, counselors, social workers, and other licensed mental health professionals, as well as graduate trainees and interns working toward licensure. Visit ComplexTraumaTrainingCenter.com to register for the 2025 NARM Therapist training that best fits your schedule. We hope you will join us to learn how NARM can transform your practice. And now for our interview. Dr. Mark L. Ruffalo is a psychotherapist in private practice in Tampa, Florida, and serves as Assistant Professor of Psychiatry at the University of Central Florida College of Medicine and Adjunct Instructor of Psychiatry at Tufts University School of Medicine. He has broad clinical experience in the psychoanalytic treatment of a range of psychiatric conditions with particular interest in the psychotherapy of schizophrenia and borderline personality disorder. During his training at the University of Pittsburgh, Mark had the unique opportunity to work with severely ill patients in long-term psychotherapy, an area in which he has developed significant expertise. He has published previously in the American Journal of Psychotherapy, Psychoanalytic Social Work, Psychiatric Times, and the Journal of Nervous and Mental Disease. He currently serves as co-director of the psychotherapy track at the UCF HCA Orlando Psychiatry Residency Program and is the founding editor of the Carlott Psychotherapy Report. His current research interests include the object relations theory of borderline personality disorder, communication dilemmas, paradoxes, and double binds in personality pathology, and deficits in logical reasoning in psychotic and borderline states. Please enjoy my conversation with Dr. Mark L. Ruffalo. All right, I'm sitting here with Mark L. Ruffalo. Welcome to the podcast, Mark.
Thank you so much for having me. I've been looking forward to it.
I'm looking forward to it too. There's a few different things that I'm curious about, but I'd like to start by asking you, what would you like our listeners to walk away with during our time together today?
Well, I imagine we're going to be spending a little bit of time talking about my area of interest, one of them, which is borderline personality disorder. And there's really a lot of misinformation in the world about this condition. It is a stigmatized condition. So I think what I'd like the listener to walk away with after listening today is just a better understanding of the complexity of this condition and not to rush to judgment about these people who really do suffer immensely in their personal lives.
I appreciate you naming that. I actually feel really touched that you're already bringing compassion into the mix because, like you said, so many are suffering. And yeah. So, I also would like to kind of ask you, could you talk about a little bit about borderline personality disorder? Like, our listeners may or may not have a lot of background on that. Can you for sure?
Yeah. So the term borderline has been used in psychiatry and psychology for, probably 80 years or so. The term originally referred to some type of condition that existed or exists on the border between the psychoneuroses and psychosis. So we can think of the neuroses as being sort of less severe psychiatric conditions and the psychoses as a group referring to conditions like schizophrenia, manic depressive illness, and more severe psychiatric disorders. So borderline disorders were thought to be somewhere in between. They were on the border. In the 50s, the 1950s, there was a concept of borderline schizophrenia, meaning that the patients seemed to be on the border of either developing schizophrenia or having schizophrenia. And many patients with what later came to be called borderline personality disorder do occasionally become psychotic or paranoid, where they have unusual experiences of that kind. So the term borderline sort of meant that the condition existed somewhere on the border with psychosis or somewhere between neurosis and psychosis. I think the concept of BPD was operationalized in the 70s by a psychiatrist named John Gunderson at Harvard, who really did a lot of the seminal work on identifying this as a distinct psychiatric disorder that was different from other disorders. And the diagnostic criteria have pretty much remained the same since Gunderson's work and since it was added to the DSM in 1980. So even though it's a relatively new diagnosis, only sort of being added to the manual in 1980, the concept has been around for a lot longer, for probably almost 100 years. I think the basic essence of borderline personality disorder is it's a disorder that's really marked by identity problems, identity diffusion, a sense of not really knowing who one is in the world, and all of the consequences that flow from that. And Gunderson argued that the core of borderline personality disorder manifests itself in interpersonal relationships, in very unstable, chaotic relationships that are often marked by a push-pull pattern where I'm going to push the other person away, and then I'm going to pull him or her back in towards me, and then I'm going to push them away again. And this becomes utterly confusing for the other person and for the patient himself or herself. Often there is a sadomasochistic element to borderline personality disorder where the patient engages in self-harm or may repeatedly find themselves behaving in ways that are detrimental to the self. And sometimes this is very clear and overt, such as cutting themselves. And in other cases, it's involvement in behaviors and activities that are clearly bad for the person. So there's sort of this masochistic element to the condition as well. I think a lot of my work has been on how borderline patients engage in terms of their communication with other people. And they often engage in paradoxical ways. And this is captured, I think, eloquently by the title of a very popular book on BPD. And the title of that book is I Hate You, Don't Leave Me, which is a paradox. And this type of communication, which we might term double-bind communication or contradictory communication, where the patient is communicating two different things simultaneously and they contradict one another, is really a hallmark of how these individuals communicate. And I think it represents a very confused sense of self, not really knowing what one wants. And the psychiatrist Gerald Adler, whose work I really like on BPD, talked about how the borderline patient is trapped in a need-fear dilemma. They simultaneously have a need for, but a fear of closeness in interpersonal relationships. And this need-fear dilemma results in a very chaotic, unstable patterning in their relationships. And I think in a nutshell, there's certainly other elements of BPD too, but that's sort of in a nutshell the essence of the pathology from my perspective.
Yeah, I appreciate you just kind of giving us that jumping off point. As you were talking, I just keep thinking, those of us who are working in the field of complex trauma, we probably heard a lot of overlap in what you were sharing and what we're working with. And so I would really be interested in hearing more about where they overlap, where there's some differentiation there. So I want to put a pin in that. But before we kind of explore that, I'd also love to come back and hear more about how you got into this work and this focus of working with borderline, and also more about you.
Yeah. So did my undergraduate degree in psychology, and then I went to graduate school for social work, and I was lucky to train in a big psychiatry department at the University of Pittsburgh. And my internship there was on a long-term unit for schizophrenia and severe psychotic illness. And then after grad school, I did some psychoanalytic training. And my initial interest was in schizophrenia. And I still see a lot of patients with schizophrenia. And psychosis. And historically, you'll see a lot of overlap between theorists and clinicians who work with schizophrenic patients and those who work with borderline patients. John Gunderson is an example of that. He began with an interest in schizophrenia and then later evolved treating borderline patients. Harold Searles is another example. But I realized that in working with patients that we would say as having BPD, they think in ways sometimes that are very similar to the way psychotic patients think. And I'll give you just one quick example. A person who is paranoid, the patient with so-called paranoid schizophrenia, may believe that his house is full of cameras and that the CIA is spying on him for some reason, and will search for evidence to demonstrate that this is happening. And it's as if he begins with a conclusion in mind and then looks for evidence to support that conclusion that's preordained, and will make connections between unrelated things. Oh, because an airplane flew overhead, that means that I'm going to become the next president of the United States. This type of psychotic thinking, connection between two completely unrelated ideas. Borderline patients do this too, but in ways that are not always so overt. So they may begin with a conclusion that my partner is cheating on me, and then they will seek evidence that that's occurring. They will look for evidence to support a preordained conviction. And the psychiatrist Silvano Arietti called this paleologic thinking because it deviates from logical thinking. In logical thinking, we make an observation in the world, and then we draw a conclusion from our observation. If I walk outside and there's a cloud of smoke outside, I say, oh, there must be a fire going on. I start making it with an observation, and then I draw a conclusion from the evidence. In paleologic thinking, which is observed in schizophrenia and to some degree in borderline personality disorder, the person begins with the conclusion already, and then they seek evidence for it. So I sort of came to borderline personality disorder by realizing that there's a lot of overlap in the way that these two groups of patients think, in the way their minds work, in essence. And so that's, to make a long story short, that's sort of how I developed some interest in BPD.
That's interesting. I mean, I did notice that your dissertation was more around schizophrenia, so I was curious how you made that jump, and that's helpful to be holding that. And I imagine, just from what I know of borderline patients, what they're sharing and what they're describing, that there often is that overlap that I mentioned earlier with trauma. And so I'm curious if you can speak to that.
Yeah. So it's a topic that I recently wrote a commentary piece with a psychiatrist named Joel Paris about. Joel Paris is in Canada, and he's in his 80s now, but he has spent his entire career on personality disorders. And certainly the concept of C-PTSD is a newer concept, one that has not been formally adopted by the American Psychiatric Association. So there's a lot of controversy around, is C-PTSD different from BPD? Is it the same illness? Is it somewhat different, but mostly the same? I will say that in borderline personality disorder, very often you do see a history of trauma or neglect. But it seems that the most relevant psychogenetic factor is neglect and not overt abuse. And a lot of the major theorists agree. Marshall Linehan, who developed dialectical behavioral therapy, places an emphasis on neglect as opposed to abuse. You might say, you could make the argument, well, it's all trauma. Neglect or abuse, it's all trauma. I think perhaps that's true, but you've seen sort of this broadening of the concept of trauma over the years. And there are those of us who think it's probably broadened too far and others who disagree. But some older research from the 90s, some smaller studies have shown that maybe 70% of patients with borderline personality disorder have been sexually abused. That's a very high percentage. Other studies don't show it quite that high, but that was an outlier, but still a large percentage of these patients have endured horrendous childhood abuse. But then you see cases where there really does not seem to be any evidence of childhood mistreatment, maltreatment, abuse, or neglect. And these create sort of a dilemma. How do we make sense of why this person developed borderline personality disorder? So some theorists, and actually it's not just a theory, there's good research to show that about 50% of BPD seems to be inherited. that there's a genetic component to this condition. And even the psychoanalytic theorists like Kernberg, Otto Kernberg, big name in the world of borderline personality disorder, has argued that borderline patients tend to have an innate inherited aggression that is something that is genetically inherited. They come into the world with some personality characteristics that may set them up, or temperament to set them up for the development of BPD. So it seems to be a condition that is very much related to difficulties in early life and childhood. Neglect seems to be the more relevant factor than abuse. But certainly you do see abuse, and you see high rates of sexual abuse in BPD. But there are also cases where neither abuse nor neglect seem to be relevant, and the patient develops borderline personality disorder anyway. So any theory of the genesis, the etiology of BPD, has to take into account these cases where there is no evidence that the patient has ever been abused or neglected. And I think that's where you run into a little trouble when we begin to assert that, oh, it's all trauma. It's all just a trauma reaction or a trauma response. Actually, in the argument that Joel Paris and I make is that, well, no, it's biology, it's genetics, it's temperament, it's aggression, and it's trauma or neglect. And so we take a biopsychosocial approach.
Yeah, that's really helpful to be holding. I was reading one of your articles, and you quote Nancy McWilliams, who we have been so fortunate to have here on the podcast. But something that she said that you continued to build on in your article was that the symptoms often, they develop in the context of the abusive and the traumatic childhood experiences. And like you're naming, there's often other factors. And I also love how she talks about that they're considered pathological defenses against anxiety. Yeah, I'm wondering if you could speak a little bit more to that. So in the cases where you would say, okay, we can see there's neglect, or maybe there's sexual abuse or some other kind of abuse, can you talk about those pathological defenses and how you see that?
Yeah, and first off, I love Dr. McWilliams' work, and she's been such a great voice for psychoanalytic therapy in a time and an era where it had, at least for a period of time, become pretty unpopular. And she's carried the mantle for this work for a long time. But I think it's so vitally important to understand that the problems that we call symptoms develop for some reason, and they develop initially to protect the person from an intolerable situation. Often they develop as a way of dealing with a difficult environment or managing anxiety. And they eventually outlive their utility. And at that point, we call them pathological. So they begin as adaptive, helping the person survive. And then the same defenses, which in early life were adaptive, begin to be applied in situations where they are no longer necessary. And they begin to be applied to the entirety of the world, such that now they have become maladaptive. And now we deem them to be pathological because they're no longer necessary. So the paradox, if you will, is that the same things that helped the person in early life perhaps survive a terrible situation later become maladaptive because now the person doesn't need to use those same defenses, or they don't need to use them to the same degree to which they've come to rely on. So, the classic example in borderline personality disorder is a defense called splitting. Splitting occurs when we engage in sort of all or nothing thinking, and we see others as either being all good or all bad. And splitting is in contrast to what we might term integration. So in healthy object relations or healthy psychological functioning, we're able to say, person X has both good qualities and bad qualities. There are things about him that I like and things that I don't like about him. But overall, he's a pretty decent person. We're able to have an integrated view of the other person. When we engage in splitting as a defense, that person is either a piece of garbage or he's the love of my life and I've never met anyone like him before. And so we split or we alternate between idealizing or idolizing and devaluing. And that's splitting, right? So the idea in Dr. Kernberg's theory is that splitting develops to protect the child in early life. They split the mother in half. So good mother and bad mother, because mother is sometimes abusive and sometimes mother is kind and nice and gives me what I need. So splitting of the object in early life, that's to boil it down, probably to oversimplify it, but we split the object as a means of protecting ourselves, to maintain a good image of mom or dad in our minds. Every child wants to maintain a good image of the parent. So we split the parent in half, and it's good mom and bad mom. And this also occurs with the self. Self-splitting is also observed in borderline personality disorder and other personality disorders, but where one day I'm smart and I'm attractive and I'm intelligent and I bring a lot to the world, and then the next day I'm a piece of junk, I'm ugly, I'm dumb, right? So idealizing and devaluing of objects, and then idealizing and devaluing of self. So, right. So the same splitting that the child engages in to protect himself or herself in early life, it later outlives its utility and it plays itself out in interpersonal relationships. So very classic pattern in borderline personality disorder is you meet a new potential partner. He or she is the best thing ever. I'm so madly in love. I've never met anyone like this before in my life. You begin to adopt the interests of this person, and it's all you can think about. And you want to have constant communication, contact with this person. You're idealizing him or her. And then, inevitably, that other person does something that you don't like. He or she does not live up to the fantasy that you have in your mind of that person. And then the devaluation begins. He's a piece of junk. I don't know what I ever saw in him. He's got a bad character. He's narcissistic. He's no good, et cetera, et cetera, et cetera. So idealizing, then devaluing, idealizing, devaluing. And borderline patients engage this way repeatedly over time in every interpersonal relationship of a certain proximity. It plays its way out in the psychotherapy relationship, where one day the therapist is, oh, I've never been treated by someone as good as you and as skilled as you, and you've helped me so much. And then because I didn't reply to an email at 1:00 in the morning, oh, you don't care about me. You're a piece of, you know what? I don't know why I pay you all this money every week. I come in here and you don't help me at all. Right? So idealizing, devaluing, splitting, classic defense mechanism in borderline personality disorder that has its origins in early life.
Okay. So you kind of highlighted something that feels really important because you named the therapeutic relationship there. And I've heard you talk a little bit about transference-focused psychotherapy and all of that. And so I'm curious if you can speak to that a little bit more, because we're seeing in the therapeutic realm, like clients, there's patterns that, like you said, they're playing out in the relationship with the therapist. And I'd love to hear more about how you work with that.
So transference-focused psychotherapy, originally developed by Otto Kernberg and colleagues in New York as a evidence-based treatment for borderline personality disorder. It's based on psychoanalytic theory. Transference refers, at least in a limited definition of it, is how the patient relates to the therapist in treatment and how certain emotional conflicts are brought into the therapy situation. So in transference-focused psychotherapy, the focus of the treatment is on the relationship between the patient and the doctor, or the patient and the therapist. That becomes the arena in which all of these conflicts and problems and dilemmas play out. And the therapist's role in transference-focused psychotherapy is really to examine, to point out, to help the patient look at how all of this is happening in real time in this relationship, in the therapy relationship. And then, of course, also to make connections to how this is a manifestation of a broader pattern that plays out with your boyfriend or your husband or your spouse or your mother or your father, right? And that this is a more general pattern in terms of how you relate in the world. But in therapy, it's almost like we have a petri dish here. We can look at it, we can examine it in a way that you're not really able to do in any other relationship. And I think that's one of the really brilliant things about psychotherapy, is that it allows us an opportunity to look at things and to talk about things that in other relationships, you wouldn't necessarily do. It would be odd to talk about these things. So, yeah.
It's so interesting when I think about, years ago when I first started becoming interested in being a therapist, I had a totally different idea of what that would look like and entering grad school and then going through trainings. What you're saying, and even still, I don't know about every grad program, but even still, this idea that you're posing, it's really challenging. And I imagine there's a lot of therapists who either entered school or even leaving school, they still have this idea that therapy is about the warm, fuzzy feelings and just helping our clients feel better. And what you're highlighting is like, that actually isn't helpful, especially when we're talking about borderline dynamics. There's a challenging piece there.
Yeah. And, of course, there's a balance. You don't want to be a jerk to your patient,
Sure.
right? But there is a proper place for, in psychoanalysis, we would use the term confrontation for confronting the patient. And you have to be wary of colluding with the patient's defenses, meaning if the patient is engaging in a pathological way, if they're engaging in a really unhealthy way in their life, let's just use an example of some interpersonal relationship, and the patient comes in and they're telling you about what a jerk my wife is, and she never does anything for me, and this and that, and she's just such a jerk. I can't stand her. Well, someone who views therapy as just this warm, fuzzy, supportive, endeavor might simply validate the patient and say, oh, yeah, you're right. Now that I think of it, you've come in and you've talked to me about your wife being this way for weeks now and this and that. And perhaps in some cases, that's a helpful approach. But what the therapist engaging in that way or working in that way might miss is a lot of the important dynamics that I mentioned earlier is, well, what is the patient himself or herself bringing into this perception? And bringing into this relationship. And so, a hallmark feature of borderline psychopathology is this victim-victimizer mentality, or this I am being victimized by persecutors. And the term would be externalization. The patient resorts very heavily to externalizing defenses. All of my problems are the result of everyone around me. And therapists can get into a lot of trouble if they repeatedly simply validate and collude with the patient's externalizing defenses. And I think this is a problem that most young therapists get into. And unfortunately, I think it's true. Jonathan Shedler talks about this a lot, and him and I agree that graduate programs are not doing such a great job training therapists nowadays. And there's been a lot of changes in training and education over the years, and certainly coming from a social work background before I did any psychoanalytic therapy training, I know that, a lot of what I learned in graduate school had very little to do with actually the conducting therapy or learning about psychopathology. So I think, there's sort of systemic problems, in terms of the educational system and the training of therapists that contribute to these problems too. And then there's just the basic human desire to be liked by our patients and to feel good about, how we relate to our patients. And this can be, in some ways, it can be a trap. Of course, we want our patients to like us, but our patients liking us should not be the goal of therapy. Self-understanding on the part of the patient is the goal of therapy, that they learn about themselves and they learn about how their mind works, as Paul Gray said. So there's a lot that can be said about these topics.
Yeah.
Yeah.
Well, you said something there too, that I'm holding this idea of like, okay, like what does that mean to want my patient or my client to like me? And is there kind of some therapeutic narcissism in there? Like, what am I actually holding there? And so, taking maybe some missteps around managing what's happening inside of me and that countertransference maybe that's coming up.
Mm-hmm.
I'm just thinking about the problems that can come from that. And so I'm wondering, in your work or like when you've worked with patients that are displaying the borderline dynamics, what can you say about that countertransference piece? Like, what do you do with that? Or like, what can you speak to that a little bit more?
Sure. Well, I think for one, you bring it into supervision and consultation if you have access to that. I think it's so important, even after, years of personal psychotherapy and psychoanalytic training and graduate school and the like, is consultation and supervision is so important. But, recognizing our own narcissistic needs, our own desires to be seen as a helpful object or helpful person. And most of us who go into therapy as a profession do so for a reason. And I think it's complicated, but one of the common reasons is to save or to rescue a broken parent or family member. Now that's oversimplified. It's not always the case, but a lot of us have some desire to rescue others. And Freud really wrote beautifully about the dangers of assuming this rescuer role with our patients. Because if we do that, one, we deprive the patient of the opportunity to help themselves. And that gets into issues of self-determination and autonomy and agency in therapy, which I think are really, really important and we don't talk about enough. When we're talking about work with patients with borderline personality disorder, this rescuer dynamic, or the rescue fantasy, as it's sometimes called in the psychodynamic literature, often leads to gradual erosion of the boundary of the treatment. And these are therapists that find themselves getting into trouble ethically with patients. They have such a need to be helpful that they're willing to text with patients outside of session times. They're willing to take calls outside of session time. They're willing to meet for coffee with a patient. They're willing to, well, instead of meeting at the office, why don't we meet at your house and we'll have a session? And then slowly there's an erosion, and then all of a sudden a major boundary violation occurs, right? So sometimes this need to rescue can, if we recognize it, we understand our countertransference, it can be very adaptive. It can make us very skilled therapists, I think. But we have to be very careful, particularly in the treatment of borderline patients who will engage in a way that may actually try to induce you to behave in unethical ways. And this is sometimes what's referred to as projective identification. I'm going to project something onto the therapist, and then the therapist is going to treat me in a way that is consistent with that projection. And very often in patients who have been abused, there is often this dynamic where the therapist becomes yet another abuser of the patient. And this is all happening unconsciously. It's not to say that the patient is doing this in some consciously manipulative way. That's not what I mean, but that these underlying dynamics are very complex, very complicated. And this is often, as Glenn Gabbard talks about, how major boundary violations occur in psychotherapy. No psychotherapist wakes up and decides, after graduating from school, that I'm going to end up sleeping with a patient. That's not how this works. Right. It's usually a gradual erosion over time. And usually there's projective identification at play.
Yeah, I'm kind of sitting with that because, again, a lot of these things that you're naming are things that, in working with clients and patients that definitely have experienced complex trauma, there's so much overlap that I'm hearing. And not all of these patients, I would say, have borderline, but they have a lot of those similar maybe tendencies or behaviors. Do you have any specific, experiences that you could name? Or
Yeah, I think I'll give you actually a great little example that I read about from someone else's work. Frank Yeomans, who is with Otto Kernberg's group in New York. I was listening to a podcast. I think it was a podcast or an interview of him. And he's talking about how he developed an interest in object relations theory after finishing his psychiatry residency. And it was one of his first psychotherapy cases. And he was meeting with a man who he described as having some combination of borderline and narcissistic personality disorders. And the patient is telling Dr. Yeomans about this really difficult experience that he had in childhood. And Dr. Yeomans, being a young psychiatrist, an emotionally sensitive and attuned psychiatrist, began to tear up as the man is telling Dr. Yeomans about this experience. And I don't remember exactly what the experience was, but the patient sees Dr. Yeomans shedding a tear. And the patient says to him, "Stop mocking me." And in this moment, Frank Yeomans says that he realized that if a patient could convert in their mind what was very clear evidence of his empathy into persecution, if the patient can convert this from me caring about you to me attacking you or assaulting you or persecuting you, then perhaps I might be able to show patients how they do this in other relationships too, how they are biased by their preconceptions and by their experiences. And so, I've had similar experiences in therapy, nothing I don't think as overt as that. And that's why I'm telling you about Yeoman's example.
Yeah, it's a great example.
But, this is the sort of thing that you see in borderline and narcissistic pathologies. And it can be quite striking to experience as a therapist, to see how the patient can misinterpret something in this type of way. And it really catches you off guard sometimes.
Yeah. I know you mentioned that you've done some work, and I think you have a paper, maybe a book coming out about the language that patients with borderline are using. That was something that also kind of jumped out at me, because that kind of binary all or nothing, that's often, something that I know folks experience when they are, that they display when they've gone through complex trauma. So I'm curious about that, whether, I don't know if it's a book or a paper. Can you shed some light and tell us a little bit more about that work?
A couple of papers. One is an empirical study that I've been fortunate to work with John Rucker at Menninger. He's a psychologist at Menninger Clinic in Texas. And then I have a theoretical paper on communication paradoxes in borderline personality disorder, which I think is actually in some ways more interesting for our conversation today. So, back in the 50s, there was a theory developed by a guy named Gregory Bateson and his colleagues in California, and it was called the double bind theory. And a double bind is a type of communication where, in essence, a person communicates two things simultaneously, and the two things are contradictory. So the classic example that Bateson gave was a little boy who walks up to his mother and puts his arms around his mother's legs to hug her. And she backs away like she doesn't want to be hugged. So she steps away from him. And the little boy, predictably, removes his arms. Mom doesn't want to be hugged. When he does that, she looks down at him and says, "What's the matter? Don't you love me anymore?" Mm-hmm. So she has placed the child into a double bind situation. She's communicated two things to him, and they contradict one another. And Bateson and his colleagues argue that if a child is put into this type of situation routinely, these types of double bind situations, they might be more likely to develop schizophrenia. We now know that schizophrenia is far more complex than just a series of double bind communications. But my paper and my work with John Rucker, we argue that patients with personality disorders are likely to engage in double bind communication, where they place other people into no-win situations or no-win dilemmas. So I'll give you a few examples. One classic type of double bind was identified by Paul Watzlawick, and it's called the be spontaneous paradox. And this is where a person requests or demands something from someone else that has to come spontaneously. An example would be, "I wish you would have more sex with me." Or, "If you really loved me, you would hold the umbrella for me." Or, "I want you to bring me flowers." So in all of these things, the meaning of these activities or these behaviors, it's only meaningful if the person does it spontaneously, right? So in communicating in this way, you're placing the other person into a double bind, because if the person does get you flowers that you've asked for, you will turn around and say, "Oh, you only got me flowers because I asked you to get me flowers." Right? If the person doesn't bring flowers home, then it's evidence that, "Oh, he really doesn't care about me," or "she really doesn't care about me," right? So this is the be spontaneous paradox. And I think that borderline patients routinely engage in this way, where it's sort of, Otto Kernberg would argue, I think, that this type of behavior is a testing of other people. I'm testing you to see if I really can trust you, or whether you really love me. And I don't think they realize that they're placing the other person in these binds. So the be spontaneous paradox is one. And then another example is what psychologist named Glover called the covert contract. And in a covert contract, it's where person A makes a contract in their own mind about something person B should do for them. But they don't communicate this to person B. And when person B doesn't do this thing, it's taken as evidence that person B doesn't care about me. But it was never relayed. The contract was covert. It was hidden. It was only in person A's mind. So maybe if my wife really loves me, she's going to bring me my favorite cake home for my birthday. It's red velvet cake. If she really loves me, she'll bring me red velvet cake. But I don't communicate to her that I want red velvet cake. I make that contract within my own mind. When my wife walks in the door with an ice cream cake instead of a red velvet cake, I conclude, "Oh, she doesn't love me. She doesn't even know what cake I want." So it was a covert contract. And another sort of paradox. Other forms of double bind or paradoxical communication. wife gets her husband, 2 shirts for his birthday. The next day he comes out of the bedroom, he's got one of the shirts on, and she says to him, "Oh, you didn't like the other one?"
Like you can't wear 2 shirts at once.
That type of communication, sort of a no-win
Yeah.
sort of dilemma or situation. So the idea is that the patient, the borderline patient in this case, was placed into double-bind situations as a child. For instance, in the case of sexual abuse, being told on the one hand, "I love you, I care about you so much, I'll never hurt you," while at the same time, that same person would come into the bedroom and sexually abuse that child, right? They were placed into a double bind. The communication did not align. And so, we could argue, well, maybe they've internalized this form of communication, and now they engage with others in this same way. They engage in double bind communications with other people. I also think it's a way to navigate this need-fear dilemma that I referred to earlier, where there's a need for a relationship, but a fear of it. And paradoxical communication is a way of sort of keeping people at arm's length and then bringing them back in and maybe pushing them back at arm's length again.
Okay, so you've talked about these paradoxical exchanges, using the all or nothing. You named the anger, like when angry words come out. I guess maybe this is similar to the paradoxical exchanges, but I've heard you name the fueling contradictory. Well, I guess that's the same thing, the fueling contradictory paradoxical exchanges. How is that being fueled?
Yeah, I think it's being fueled by the patient's own internal dilemma. And again, I think the dilemma centers on this idea that neither closeness nor distance is tolerable for me. So it's like the patient is turning on a faucet, but they have to make sure that not too much water comes out, but they also don't want it to drip. It's like, or to flow out. It's like there's always like this attempt to regulate the proximity in relationships. And person gets too close, I'm going to feel smothered and I'm going to feel too vulnerable.
Yeah.
But if the person's too far away, I'm going to feel traumatically abandoned. And fear of abandonment and the fear of enmeshment or engulfment are the 2 major fears in borderline personality disorder.
Yeah.
So we can think of, or at least I think of, these paradoxical exchanges as a way of navigating or regulating this need-fear dilemma, or the balance between fear of abandonment on the one hand and fear of enmeshment or engulfment on the other.
Okay. Yeah, that's so helpful to be thinking about these. And even just having the languaging, like knowing the terms is really useful, I think, in being able to tease it out, like when it's right in front of us, like being able to understand what's happening. I want to be mindful of the time, but I wondered if before we left, if there's anything else that maybe especially a new therapist, or like, what do you want therapists to really know and understand when they're working with these clients?
Yeah, I think these are clients or patients that historically have been termed the difficult patient. And frankly, they can be difficult. They can be. The term borderline is often used pejoratively, and I used to work in hospitals, and it's often misused and misapplied. And there's a moral judgment sometimes that comes along with the use of the term. In essence, there's this sort of unspoken idea that the borderline patient really, if they tried hard enough, can change. If they really tried hard enough, they could overcome their challenges, right? We don't think that way about bipolar illness or schizophrenia. It's not a matter of will. So the patient with borderline personality disorder faces terrifying fears of aloneness and abandonment. Really terrifying experience for these people. Yet they act in ways, paradoxically, that almost ensure that outcome by pushing people away, by engaging in these contradictory ways. This is a very nuanced, complicated condition. And the relationship between you and the patient is even more complicated because you've got 2 psychologies at play. You've got the patient's mind and your mind. And so I think the take home, if you will, I think ought to be any attempt to oversimplify this condition, this really complex condition, I think is bound to fail. This is a problem that's been described in the literature, again, for almost 100 years. Some of the brightest and the greatest minds in the history of psychiatry and psychology and the related disciplines have worked on this problem. We can't boil it down to a single cause, such as biology or such as trauma. This is a really, really nuanced problem that demands not only our attention, but it demands our care and our thoughtfulness, our theoretical mindedness, our appreciation for the suffering of the patient. So, these patients can make us uncomfortable, but behind that is the patient's immense discomfort. And I think so often we get lost in our own feelings, navigating our own countertransference, and we lose track of the fact that the person sitting in front of me is suffering immensely. And so I'd like to bring it all home with that idea.
Thank you so much, Mark. I really appreciate your generosity, the time that you've spent here with us. And I'd love to be able to share with listeners where they can find more of your work.
Sure, yeah. My practice website is drruffalo.com. That's DRRUFFALO.com. And I've got a list of publications there, and so you can find more about me there. And I'm also on Twitter or X at Mark L. Ruffalo, RUFFALO.
Great. Yeah, I don't normally recommend social media, but you and Dr. Shedler, there's a handful of you doing such important work that has really made it so accessible. I think of 10, 15 years ago, the kind of work that you're doing, writing papers, it's very intellectual. And I just don't think that a lot of that was very accessible to a lot of us kind of.
Yeah.
And so that's one way that folks can, maybe they're not clinicians, but they're just really interested in the work that you're doing. And so that's one really great way and I think that your posts, I really appreciate you kind of boil things down in really understandable words. You're not using the big words that we're often reading in papers. Yeah. So I appreciate your ability to do that.
Well, thank you for those comments, Emily. It's been lovely.
Yeah, it's been great.
Thank you for having me.
Thanks for coming. Thanks so much for joining us for today's episode. To find more information about our guest, check the show notes or visit us at complextraumatrainingcenter.com/transforming trauma. You can also connect with us in other ways. We're on Instagram, Facebook, and YouTube. As a mental health professional, your commitment to healing and growth inspires us. We at the Complex Trauma Training Center are committed to supporting you in your well-being and success. That's why we're honored to invite you to our Space Program 2025, an interdevelopment program of support and self-discovery for therapists on the personal, interpersonal, and transpersonal levels. Running over 6 online sessions in 2025, this interactive experiential learning program is designed to support self-care and self-discovery for therapists, exploring internally, relationally, and transpersonally. CTTC faculty will welcome you into a professional community of therapists that are seeking to create greater effectiveness and resilience in our professional lives. As CTTC faculty Brad Kammer says, the intent is that this program will help us not only become more effective therapists, but also love our work more. Please visit complextraumatrainingcenter.com and secure your spot in the 2025 Space Program. Thanks to Andrea Klunder and the Creative Imposter Studios for producing and editing, to Elisa Sponseller for our album art, and to Brad Kammer for the creation of this podcast. We look forward to building community and connection with you and changing the world by transforming trauma.